Welcome to Your Doctor Wants to Quit, a podcast inspired by the need to save healthcare in America. I am Dr. Joy, a board-certified emergency physician, and I created this podcast to shed light on the challenges our healthcare system is facing through the multiple lenses of doctors, other healthcare professionals, and patients. By listening and working together, I believe we can fix healthcare in America for all of us.
The business that we're in is improving health. That requires a unique degree of empathy and humanism to run the business effectively. We have to have systems that are viable economically, and yet we have to remain true to our mission. There is so little room for error, and the pressures under which we're practicing, more patients, less time, sicker patients, more complexity, more treatment options, more venues of care, more information, more misinformation, make it really hard to do our job at the bedside. It takes virtually all of our energy just to do that in a way that's safe, effective, impactful, and maintain our health and sanity. The system does not have endless resources, and physicians are the stewards. We know how to manage patients. We don't necessarily know how to run effective systems. We don't necessarily have the operational, technical, or financial savvy to ensure viability. And so the complexity of the work and the complexity of the system have forced the issue that if physicians want to be at the table and not just on the menu, we have to develop these skills.
You are hearing the voice of Dr. Dan Meltzer, emergency physician and executive medical director for Regence Blue Shield of Idaho, a not-for-profit health insurance company that served more than 370,000 people last year. Dan's role at Regence is to provide clinical direction, medical oversight, expertise, and leadership to ensure the delivery of affordable, quality healthcare services. I first met Dan working in the emergency department at Kaiser Permanente in San Diego, and he has been a trusted friend and colleague of mine for the past 13 years. I am thrilled to bring you this interview today, because if there is one physician insider in the insurance industry who can help us unpack what's really happening, who can help us find solutions and common ground, it's Dan Meltzer.
My name is Dan Meltzer. I'm an emergency physician. I currently live in Boise, Idaho. Most of my clinical practice was in San Diego, California. I did my residency at UCSD, and then I chose to work right out of residency at Kaiser Permanente. I was there for about 17 years. The latter half was the chief and chairman of emergency medicine, a very big, active department. We ended up evolving from sort of a very busy community-based practice to more of an academic one. We set up a residency program and even some fellowships. So I had the opportunity to help lead and participate in that part of a clinical practice as well. Currently, I'm the executive medical director for Regence Blue Shield, which is a large health plan in the Pacific Northwest. Regence is part of a 4-state health plan in Idaho, Oregon, Utah, and Washington, and I help lead the Idaho plan. I still maintain a clinical practice. I'm still board certified and licensed, and I practice clinically through a large system called St. Alphonsus, which is a division of Trinity, which is a big system based out of Michigan. That's become a little bit more my avocation than my vocation these days, but I still do enjoy the clinical practice of medicine.
Maybe it would be worthwhile to take a moment and rewind a little bit so that we can all hear a little bit about how you ended up going into the current role that you are playing now, working for an insurance company. I know that some of my physician colleagues that are listening to this might be cringing at the idea of a physician working for an insurance company, but I'd like them to hear it from you. What drew you to that role and what you find meaningful about the work that you're doing?
The true story is there I was kind of minding my own business when all of a sudden, I actually got recruited to be the chief medical officer of a blue plan. And, you end up on someone's list, or someone saw you talk somewhere, or someone looked at a CV, online, or found you on LinkedIn. And, I was getting recruited for a position in Idaho, which is not exactly where I necessarily thought I would end up, working at Kaiser Permanente, which is an integrated entity. Even though I was a practicing physician on the medical group side, I had the I think good fortune of many times being elbow to elbow with people on the health plan side, trying to make decisions. How do we ensure the greatest kind of bang for the buck? How do we manage our resources when managing, I don't know what it was, 600,000 patients or so when I was in San Diego? I guess I became curious about the system in which we work. I've been on the provider side and I've been on an integrated side. And is this another worldview into healthcare, which is obviously the business that I'm in? And I was curious about learning more. And as you learn more about what health insurance companies do, as physicians, it's really a lot of population and preventive care. How do you think about managing clinical entities like cancer, cardiovascular disease, metabolic syndrome, musculoskeletal illness, joint replacements, pediatric entities? How do you partner with physicians to create viable payment models? How do you work with people that are paying for their health insurance, both members and employers? And it just became a macro view of healthcare that I was frankly curious in. And as I learned more about it, as it turns out, health plans have tons of physicians in their walls doing really good work, many of whom still practice clinically, most of whom don't, but many of whom do, that are, I think, similarly in line in that they want the best for the patients, but we're trying to make these systems viable. So honestly, Joy, again, it's a design default thing. I was curious about it, and then all of a sudden I found myself with this opportunity to learn more. And I've been in that kind of role now for, 8 or 9 years.
It's probably not a coincidence that Dan's career path as a physician has taken him in a unique direction. People whose interests lie at the intersection of industries tend to be change makers, and Dan's gravitation towards both medicine and business began at a young age.
I didn't have a straight line through to medical school. I finished up college, and perhaps much to my parents' chagrin, was an unemployed Ivy League graduate living at home, bussing tables at night. Even though I was pre-med, I wasn't convinced, and I ended up somewhat fortunately connecting with family friends, and there was a physician who had started a healthcare management consulting company back in the day. This is the early 90s, where it was relatively unusual at that time for physicians to sort of cross the bridge to really begin to think about systems issues in healthcare outside of the bedside, where physicians could lean in and lead and use their expertise. And he and his partner had gone back and got MBAs and were advising systems on how to integrate or evolve their clinical practice and bring physicians along. And that really got me curious about how can we, as those that are interested in healthcare, either as a physician or not as a physician, make a dent in healthcare in a broader way. And so I actually went to graduate school first in public health, specifically in health services administration, and in many ways thought I would be sort of a healthcare administrator. Turns out, ironically, a lot of the classmates that I had in that program were actually physicians who were going back later, realizing that they hadn't learned all they needed to in medical school. Now that they were seasoned clinicians, they were being tapped for leadership positions. So how do I lead effectively? How do I run a team? How do I think about a profit and loss statement or a balance sheet, or scale a business, or run departments? And those kinds of skills became imperative for them. And so I kind of did it in reverse. I did that first, and then I realized, wow, this is good stuff. And oh, by the way, if you want to lead in healthcare, it helps to be a physician. And so I talked to my mentor, who said, well, great, here's what you do. You go to graduate school, and then you go to medical school, and then you go to residency, and then you need to practice and gain credibility. And so I'll see you in 20 years if you want to come back and be a physician executive. And that's kind of what I did. I think if we want to make an impact on the system, we got to get comfortable with being uncomfortable. And if you're not in it, you're sometimes, stepped on by it. So I put myself in this position because I enjoy it on some level, and I feel like it's impactful. And I also feel like it's imperative.
So what is your actual job? Can you kind of break it down for us so that we can have
my job, and I think it's like, you've seen one job, you've seen in a health plan, you've seen one physician in a health plan. I would say, let's talk more broadly, what do physicians do in health plans? Many physicians are doing, frankly, a lot of case review. I don't do that in my current job, but a lot of physicians, we have essentially specialists from just about every specialty. And if they're not staff, then they're contracted, everything from radiation oncology to pediatric nephrology, that are kind of scouring the data with our medical policy team. So there's a medical policy team, which is PhD scientists, public health nurses, and physicians that are scouring the literature every day and on an annual basis, trying to put together medical policy that ensures the safest care for knee replacement, cancer screening, pick your clinical entity, and doing what we call utilization management to make sure that that care makes sense medically, that care makes sense economically, it's being delivered in the right setting. Sometimes it's managing medication. So much of that, frankly, is clinical work on a population and sometimes an individual level. I am not currently doing that, but I'll tell you what I'm doing in a second. You have a question.
Yeah, I definitely have a lot of questions about that. And I know that our listeners have a lot of questions about utilization management, which is sort of the euphemism for prior authorizations, right?
Well, it's part of the prior authorization process. It can be. Yeah.
Yeah, so prior authorizations fall under utilization management, right? Yes.
Prior authorization is the process whereby physicians, in some cases, not all cases, have to seek approval for the delivery of medical care. Why is that? It's because for 5 to 10% of medical care, there can be high degrees of variability. I would say that most of the medical care that's delivered either does not require prior authorization, or that prior authorization is often automatically approved if very rudimentary factors are followed. For example, most advanced imaging we know is going to require non-advanced imaging. Not all of it, but most of us are pretty familiar with you get the X-ray before you get the MRI. And I think most of us realize that clinically that generally makes sense. There may be external factors for which that's not the case. So I just want to also talk about that, double click on that point, which is to say that most clinical decisions do not require from insurance companies any deep prior authorization because the standard of care is typically met. What we're talking about generally is like a 5 to 10% variability. And we know in any system from an engineering standpoint that there is variability. And it's that 5 to 10% that either it represents clinical variability or opportunities to deliver care in a way that systematically may be more cost effective. For example, site of care, where the care is delivered, you and I know can have massive impact on the cost of care. Sometimes that's not avoidable. Emergency department care. Someone has chest pain. We know in retrospect they could have been seen in urgent care, but no one's telling them to go to an urgent care if they have chest pain. And yet we know it's 10 times more expensive in general to go to an emergency department than it is to go to an urgent care. But the one thing I will say that the health plans really have their eye on that I don't always think delivery systems or providers do is affordability. They're the capacitor for affordability. And why is that? It's because we're taking the risk. And what I can tell you from talking to hundreds of either brokers, people that sell insurance, or people that own businesses, is that is the fundamental issue in their mind with healthcare right now. They can't afford it. They simply can't afford it. So health plans work to adjudicate costs so that they can be affordable for all. And physicians in general aren't attuned to that. And I don't know that we always necessarily should per se, but it does make a difference from a population standpoint because that pass-through of the cost ultimately goes down to individuals, which is why we see insurance premiums running 10 to 15 to 20% a year because the costs keep going up. That's a bit of a ramble, so let's pause and let's double click on whatever you want to.
Well, I guess one of the responses I have many responses to what you're currently describing. One of my responses is how could physicians possibly have even an awareness of what things cost because there's no price transparency. When I order an MRI of the lumbar spine for my patient, I have no idea what the health plan is going to have to pay for that. I actually probably have a better sense of what the self-pay rates are for my patients because if that MRI doesn't get approved, then we have predetermined with the imaging center, like what the self-pay rate is going to be if the patient wants to move forward. But the whole fee schedule in healthcare is extremely chaotic and impossible for anyone.
Totally, 100% agree.
Because it's not like there's one price for one thing. There's like 20 different prices for one particular thing, depending on where that test is performed, who's performing it, which health plan's paying for it. I mean, it seems like, depending on which way the wind's blowing, it might be a different cost. And so
yeah,
how do you have any rational decision making in a system where you really don't even know what things cost? Doctors don't know what things cost, patients don't know what things cost. And then you have an entity like the insurance company, which is kind of then put into this role of having to adjudicate cost. But you're also the only ones that actually have full transparency on the cost.
Yeah, no, you're 100% right. And that's a system that neither you nor I created. And
exactly.
in large measure, that ultimately stems from how the federal government chooses to pay for healthcare, and health plans tend to adopt that, whether it's DRG, CPT, and all that crazy coding. What I will say in terms of my role, so you ask kind of what does Dan do? One of the things that I do is I spend a lot of time talking to physicians, which I love since I am one, and talking about these exact kind of issues, and trying to unblind or demystify cost and quality. Now, the reality is there are some regulatory barriers to freely discussing cost, once again, that neither you nor I, created. So at times it requires mindfulness of that. But I will give you a perfect example. Last week, when I was delivering grand rounds, my topic was on sort of acute care optimization. And I don't like the term avoidable emergency department, because I don't want people to avoid the emergency department. That's where we work. And I think a lot of people need to be there. And I think we do great work. But how can we as a system optimize acute care needs, real or perceived? And I was able to share with this group their data. So one of the things that the insurance companies have is data, and what their costs are, for example, when a patient is seen primary care versus urgent care versus the emergency department. So that they became aware of, like, holy crap, it's $1,500 for the emergency department, it's $180 to go be seen in my office, whether that's an uncomplicated UTI or an uncomplicated UTI. So sharing data, and then also not only quantitatively what do things cost, but what are some of those conditions that we think might be avoidable, and we use the New York University algorithm. So when we talk about uncomplicated urinary tract infections or headaches, musculoskeletal complaints, or upper respiratory infections, the kinds of stuff that you and I know very commonly end up in the emergency department, that if managed early and appropriately could be seen elsewhere. So here are the kinds of conditions, and here are some of the factors, and here's what the health plan is doing. Here's the resources that we have in terms of an advice line, in terms of home care options, in terms of case managers, in terms of the ability to identify primary care physicians and help people get appointments to work together. And so that was the kind of conversation that I have to illuminate some of these issues. What does it cost? What are our options? What can we do collectively to manage this population? The other good news with that conversation is many of those contracts were value-based, so they had skin in the game. Mm-hmm. And we haven't talked about that, but when the payment incentives are such that they're aligned in terms of doing, quote, the right thing, and then you can provide the data accordingly, I think that's how you get a better handshake.
Yes, as long as we all agree on the outcomes that we're measuring and how they're being measured, which Great. I mean, the devil is always in the details, right?
Yeah, and I think, look, in some cases that those are defined for us, right? If you look at HEDIS and STARS, right, it's certainly in the Medicare line of business. I mean, like it is, like, that is what it is, and insurance companies get paid and physicians get paid, and so we, for better or worse, there are a defined set of metrics. I can tell you in Idaho, having those be related to vaccinations, even though you and I know it makes sense, drives physicians crazy because it's impossible to get people vaccinated because of the anti-vax movement. So physicians don't necessarily like being measured on that because it's a really tough boulder to push up the hill. But in general, we know what some of those metrics are. And I think most of them, at least in a primary care setting, make sense.
Yeah, I think it's tricky.
No doubt.
You have metrics that essentially require the patient making a decision for themselves, for their bodies, and then you're holding a physician accountable for whether or not the patient chooses to do that.
Totally, 100%.
A really major ethical dilemma with that. Statins is another example that we run into all the time. So there's a metric where they're looking at how many patients have a diagnosis of hyperlipidemia that have been prescribed statins. Yep. We have a pretty significant chunk of patients that don't want to be on statins for their own personal reasons.
Yep.
They want to try lifestyle changes first, or they have a variety of reasons why they don't want to take statins. I'm not saying that they're always great reasons, but it's still the patient's choice, the person's choice to put something into their body. And when you create a metric like patients that have hyperlipidemia diagnosis in their chart have to be on statins, and if not, physicians are held accountable to that, what you're essentially doing, and not you, I'm saying the government, because the government creates these types of metrics, you're kind of driving a wedge in that doctor-patient relationship, because you're putting the physician at odds with the patient to try to convince them to do something that they don't want to do, that they feel some kind of ethical or moral problem with. And I mean, it's really, at the end of the day, not my job to judge people for how they want to manage their own bodies and their own health. I know vaccines are a different story because there's a public health aspect to it. If you contract a disease that's preventable, that's contagious, and then you pass it on to someone that's immunocompromised or something like that, obviously it's not affecting just you. But if you don't want to take statins, that's not necessarily affecting your neighbor. And I think there's a need to reframe some of these metrics. Not to say, I mean, I'm 100% for lowering LDL. Obviously, we need to do that. What if you accomplish that through another method? Like, what if the patient has hyperlipidemia and through diet and exercise and supplements, you get their LDL down to 70?
Yeah,
But you
I think
that.
you're bringing up a really good point, which are process versus outcome measures. I think on some level, and I think again, we don't always choose the measure when it's in a government line of business. Having said that, right, for other lines of business, so for commercially funded, whether they're fully insured or self-funded, sometimes there are opportunities when working with providers, practitioners, physicians, clinicians, et cetera, to co-design metrics that are more outcome driven. You're right. We are very often handcuffed by process measures, right? And in your case, what you're talking about is the statin is a process measure for the ultimate outcome, right? Which is lower, in this case, lowering LDL, total cholesterol, et cetera. And you're right. Sometimes we are that is done to us, but other times it can be designed by us. And that, the latter, I think, for example, is something that I found worked fairly effectively when I was at Kaiser, when we were able to co-design quality measures very oftentimes between the health plan and the physician group. Whether that was the emergency department, surgical cases are a really good example. So even things like throughput or hospital site, surgical site of infections or catheter-associated UTIs, all the ones that, even though some of those are government related, most physicians would agree on them. And when and where possible, when physicians and non-physicians, if the case may be, can co-design those, and they're meaningful outcome measures, I agree, we can all kind of stack hands around them. And other times we're stuck, and that's what makes the system really challenging.
A point that is worth a little bit more discussion is the uncoupling of business experience from medical training or the practice of medicine. Just thinking back to the Norman Rockwell idea of what a family doctor is, and even to some extent how other healthcare professionals currently practice. Optometrists, dentists, most of them are business owners. Most of them are not part of a large corporation. And in our field, in medicine, over time, there's been so much vertical integration and consolidation in the healthcare industry that physicians have really become employees, really, rather than leaders or business owners in many respects, and especially for hospital-based care, like emergency medicine or internal medicine internists that are doing hospital rounds. But even outpatient specialty care is, for the most part, not physician-owned as it once was. And so I'm just wondering if you could speak to that a little bit, just with your experience and also having been along for this ride for the last 20 years at least, practicing medicine and seeing how things have evolved. What do you think is the primary driver for why physicians have sort of been siloed from the business side of medicine? And what are the pros and cons of that, and where are the gaps?
First of all, I think it's really hard to become a physician, and it's even harder to remain a good one. There is so much information and expertise that we're expected to have, and there is so little room for error. And the pressures, the external constraints, if you will, under which we're practicing, more patients, less time, sicker patients, more complexity, more treatment options, more venues of care, more information, more misinformation, make it really hard to do our job at the bedside. And so I think it takes virtually all of our energy just to do that in a way that's safe, effective, impactful, and maintain our health and sanity. I can't think of another profession that faces similar challenges in terms of the work that we do and the constraints that we face. And so it makes it really hard to add on more to that with time and energy that we don't have. And yet the healthcare system is unbelievably complex. There's nothing like it in the world. There's no paradigm from which we can extract information really in terms of running the system. And the system itself in which we work has become more complex. So that conspires against the simple task of trying to practice medicine. And yet we know that even if you're employed, you are held to, and I think to some extent rightfully so, certain measures and metrics in terms of efficiency. The system does not have endless resources. and physicians are the stewards. We drive 90% of healthcare expenditures. We write orders. I mean, judges, drill sergeants, physicians, there aren't a lot of professions where you actually give orders that are legally binding on some level. And so I think, we've had to focus on what we're doing, and we've been fortunate that other people have kind of managed the system on some level. And on other levels, we've said, no, we know how to manage the system better than any, but we really don't. We know how to manage patients, but we don't necessarily know how to lead. We don't necessarily know how to run effective systems. We don't necessarily have the operational, technical, or financial savvy to ensure viability. And so the complexity of the work and the complexity of the system have forced the issue that if physicians want to be at the table and not just on the menu, we have to develop these skills.
I think you're right, but maybe one of the nuances in this is that if physicians completely give up leadership and completely give up having at least their foot in the door on the business side of medicine, how does that change the practice of medicine and the care delivery model to have non-physicians running the business side of medicine and physicians only doing the practice side?
It doesn't work well. I mean, it's why, at least for me personally, before I even became a physician, felt like having some sense of this language and skill set was imperative, if not to just protect myself, but to protect patients and support colleagues. I think we've seen in many cases the best systems in our country, physicians are leaders, right? Whether it's big academic centers or tertiary or quaternary centers of excellence. You mentioned you were at Mayo Clinic recently, or places where I practice, Kaiser Permanente, where health plans, hospitals, and physicians are integrated. If you look at most of healthcare outcomes, those kinds of systems where physicians are in leadership positions tend to have better patient outcomes. And by and large, they tend to have more satisfied physicians. So there's a paradox there. I think the other thing is we probably want to differentiate business from leadership. I think leadership is a skill that is imperative in business and in healthcare in general as an industry. And so part of running the business means being an effective leader. And that means how you communicate, how you listen, how you give feedback, how you receive feedback, how you manage change, how you onboard people, how you maintain empathy and continue to validate, how you maintain your own emotional well-being. And not all of that is taught. In fact, very little of that is taught. But those are skills that physicians can, and I would argue should and must learn, simply to be able to articulate whatever it is they're advocating for, even if it's basic science or patient care. That's a fundamental part of running the business. There's the operational piece, which I don't know that physicians necessarily need to have massive expertise in, whether that's the quantitative piece or the analytic piece or the operational piece or the process improvement piece. I think we should, but I think you need to be able to speak intelligently to rooms of people, and that's basic communication and leadership, which frankly is not so basic for many physicians.
I hear you. I think we can always do better. And the medical education focuses mostly on pathophysiology and treatment of illness. It doesn't focus as much on those leadership skills. I think inherently a lot of people that have leadership skills are drawn to the field of medicine because it takes a certain personality to kind of get through all of the hoops that you have to jump through to get into medical school in the first place and then to survive medical school. But I agree with you that there's still a big gap in what physicians could learn to be more effective in leadership roles in their organizations. I do think that organizations like the Mayo Clinic or Kaiser that have physicians in leadership roles, they make that choice, and it's a conscious decision. I think it's a cultural decision to have physicians rise up through the ranks and take on those leadership roles. Not all health systems do that. There are many health systems where you don't have physicians in leadership roles. And I think it is a little dicey to have a healthcare organization where there are no physician leaders and it is strictly non-practicing, non-medical people that are in charge. If you have leaders that are non-clinical and then you have people that are clinical that are supposed to do the work, the incentives may not always be in alignment, and there may not always be a mutual understanding that creates or fosters a working relationship between those two different groups of people that is effective for patient care.
Yeah, look, I think at the end of the day, I would hope that most of us went into medicine as practicing clinicians to care for people. Most of us, I think and hope, have some modicum of empathy. And the business that we're in is improving health and improving healthcare outcomes and improving health span and lifespan, sometimes one or the other and sometimes both. that requires, I think, a unique degree of empathy and humanism to run the business effectively. And when you lose that, you lose the soul of the business. And I think physicians are, and I would argue nurses as well, and other clinicians, pharmacists, et cetera, are that clinical soul. And yes, it's imperative that we run our businesses and our industries efficiently and effectively. Everyone knows the no margin, no mission statement, and it's truer than ever as we see systems consolidate, as you mentioned, with vertical integration, as we see more and more health plans not covering certain lines of business like Medicare Advantage, as we see more patients and not enough physicians. Right? We have to have systems that are viable economically, and yet we have to remain true to our mission so that our intrinsic motivation of why we're doing this, right, our mastery, our autonomy, and most importantly, our purpose are fulfilled. Otherwise, we become burned out.
Becoming a physician is not just like getting a random degree. There's an element of it that is deeply personal because we are participating in people's lives in some of their most vulnerable moments in a very intimate way, in a way that really changes us on the inside as we go through training and practice as the years go on. It's transformational in terms of our identity and how we see the world. And so, of course, business decisions need to be made. There's not unlimited resources, but when you have people that have been at the bedside and seen the impact of certain policies or care rationing or nursing ratios or whatever, whatever the thing is that we're making a decision about, having physicians in a leadership role, you have people that have been at the bedside and seen the outcome of that and the impact it's had personally on people, on human beings. I think it lends a lot of insight into how to prioritize decision making. I think you have to be able to evaluate the data, but I think you also have to have that personal experience of what the end result is going to be able to weigh those difficult decisions appropriately, in my opinion.
Yeah, 100%. I think, as physicians, we are generally focused on an N of one, which is the patient that's in front of us, right? And I think we should. That as patients, and we're all patients at some point or another, that's what we want. I think where additional partnerships, both clinical and non-clinical, can be helpful is thinking about populations in addition to patients. And I think what I've learned in kind of pulling the aperture open and seeing healthcare from a variety of lenses is that it's important to account for both. Otherwise, you get a little bit of the tragedy of the commons where in sort of just advocating for self or for patients, sometimes it can conspire against the system. And, we see that with utilization resources, for example, if we all wanted our CT and MRI at the exact same time, right, because we felt it was best for our patient, how do we prioritize? So there are finite resources. And so how do we as physicians gain insight into those resources so that we can make decisions not only for our patients, but for the systems in which we work and be stewards of it? Those are blind spots for us in general. And I think that's where effective partnerships, often with non-clinical individuals who are at least open and empathetic, can lead to better decisions for the system itself. And the system is having a really hard time.
Yeah, that is true.
It's never been harder.
Yeah, I don't see the trajectory getting any better. But I do think that there are mitigating things that can be done that aren't being done that can make it better than we currently have today.
Yeah, I think it's going to be different, right? I don't know that it's going to be better or worse. I think, I try to maintain my nature, which is optimist. My son used to call me a poptimist when he was a kid.
You're his pop and you're an optimist.
Yeah, he used to say, Dada, you're a poptimist, which I still kind of like. And I think if we don't on some level, we become cynical, which becomes the sewage of our soul as physicians. And I just try not to go there. So I am actually excited on some level with the technological advances. It's certainly a lot easier to do a note now than it was in 2007 when I first got on Epic. Is it as easy as sort of like doing a quick, dictation into a tape recorder like I used to that I held and then stick that tape recorder in an envelope and all of a sudden my note would come back? I don't know that it's that easy, but I also don't know that note was as effective either for my colleagues, even though it was easier for me. So I am optimistic about some things, but I think there are at least, if nothing else, there are epidemiologic dynamics that are going to be really challenging for the system.
Yeah. And you and I both have a public health background, so we can also look through that lens, not just the physician lens that treats the N of one, but the physician that treats a population like you were mentioning, where there's always an opportunity cost, right? You advocate for resources for one person, there's a finite number of resources, and then that means another person may not be able to get the thing that they needed. And it really comes down to, in my mind, triage in a way. As an ER doc, maybe that's just my knee-jerk way of kind of framing things, but we do have to triage how we leverage resources in our healthcare system. It's unavoidable. We do not have unlimited funds. We do not have unlimited doctors. We do not have unlimited nurses. We don't have unlimited hospital beds. We don't have unlimited pharmacies even, or supplies of medication and things like that. So we have to figure out how to triage and, like you mentioned, be good stewards of resources. At the same time, if you triage incorrectly, the results can be catastrophic. And I think that's one area of concern that I have is, like, how do we do that in the right way, in the way that serves patients' needs and avoids some of the pitfalls of the perverse incentives that are out there that can interfere in how we triage the use of resources?
Well, yeah, I mean, look no further than primary and preventive care, right? It's sort of the obvious from a public health standpoint, and yet, to your point, in terms of how care is incented, certainly economically, and these days politically, it's not necessarily where dollars are being spent. And you and I know, in general, the greatest ROI from a population standpoint is in primary and preventive care. And yet we're losing primary and preventive physicians, and we have more and more orthopedic surgeons coming out of residency. No disrespect to my beloved orthopedic surgeons. I'm seeing 2 of them currently in my own healthcare journey. So God bless them. But you're right. The system does not necessarily incent what we think makes sense medically, which is not something you and I are necessarily going to fix. Although I would say, as we think about ways that reimbursement, which is a topic we haven't talked about, right, is evolving from fee-for-service to more value-based models, right? We do hope that there are ways to align what we think are clinical incentives with population incentives, with economic incentives. And so payment reform and payment innovation becomes important for building and designing sustainable systems. If you look at what's happening in the Medicare Advantage market, which is massive consolidation, right? Insurance companies are pulling out the Medicare Advantage market, which means that, millions of older adults are losing access to what in many cases is a more affordable form of health insurance, because the cost and utilization dynamics are such that insurance companies cannot continue to take the risk because of the lack of payment that they're getting from the government. So in order to get that payment in the form of a risk adjustment factor, or stars as the case may be, right, you have to kind of play this game. So we're all in it together, and it's challenging.
Yeah, I think it'd be good to maybe back up and explain to the audience what is a Medicare Advantage plan versus original Medicare, because I have plenty of patients on Medicare Advantage plans that still don't understand what is a Medicare Advantage plan. It's very confusing to the consumer, I think.
So most people, I think, in theory, are familiar with, OG Medicare, right?
Yes.
The government-funded health benefit plan provided to older adults beginning at age 65. Medicare Advantage plans are private insurance plans that essentially provide an alternative way to receive Medicare benefits. And they can and generally do combine the coverage of what's called Medicare Part A, which is hospital insurance, with Part B, which is medical insurance, into a single plan. And they often will include Part D, which is the prescription coverage. And that, in theory, allows individuals to receive those healthcare services under one plan with one card. That's the thesis.
I don't understand how they're able to make it so much more affordable. I mean, it seems to me that you would have to cut costs in a certain area to be able to provide
That's
coverage
correct.
things, right? So
Yeah.
there's got to be a pretty heavy dose of utilization management to provide care at a lower cost to offset the extra cost of covering things like medications without charging any additional premiums.
They are required to cover everything that original Medicare covers: hospital stays, doctor visits, preventive visits. And they may offer additional benefits like vision, et cetera, et cetera. Where they sometimes will differ is in the network. And that can be where the cost game comes into play. So there can be network restrictions, meaning the breadth and depth of physicians that beneficiaries can see may be narrower than the full ocean of quote doctors out there. The problem that has happened lately that where you're seeing it from many blue plans, you're seeing it from Cigna, which sold off its entire Medicare Advantage business. They're no longer providing Medicare Advantage. You're seeing contraction with large plans like Humana and even United Health in certain areas, is that the funding that they receive is less than the cost of providing those services. So they're having to consolidate.
Yeah, and I mean, you're also seeing it on the other side too. You're seeing providers, large health systems stop accepting Medicare Advantage plans because the reimbursement is not there in order to
Correct.
support the cost of care.
Correct. And for many individuals, Medicare Advantage plans are less expensive than Medicare. Medicare is not free. I think there's an illusion that people have Medicare. Medicare costs most individuals anywhere from $200 to $500 a month. That's your premium. And there often are other deductibles and things like that add on to that. So Medicare Advantage was conceived as a less expensive way to scale access to health insurance, and in some ways a more affordable and flexible access to millions of Americans. That paradigm is now being tested.
Mm-hmm. And what do you think is the root cause as to why it's failing?
Well, I think what we've seen is a couple things. Certainly we saw during COVID, as everyone knows, a reduction in utilization. I think part of the reason it's failing is because our healthcare system is failing, meaning we expect, for example, a 60% increase in people with 3+ chronic conditions by 2030. We have sicker, older people. The cost of caring for those patients is going up. The utilization of services is going up. The means by which we treat them, medications in particular, the cost is going up. So it's simply there are more people seeking care for more things, and those treatments are often more expensive. Oh, by the way, the reimbursement that we're receiving from the government or elsewhere is going down. You don't need to be an economist or a business person to understand that. That's probably one of the most fundamental dynamics why the system is failing. Healthcare is more expensive, people are sicker, there aren't enough people to do it, it's more complex, it's more expensive to deliver the care. I mean, that's really the bottom line.
And I wonder, is it really because people are sicker, or is it because we have an aging population and the proportion of people above certain age is greater than it was in the past? And also we have more tools to keep people alive longer, and so they're living far past the age of 65 when they qualify for Medicare?
I think, right. So it's, when I say sicker, I'm talking about chronic disease. I'm meaning there are more people living longer, so that have more chronic illnesses. So it's complexity of disease. Let's take one example, which is cancer. Cancer is now, in many cases, a chronic disease. Mm-hmm. Cancer has become very different in terms of how we think about it. And yet we know for many health plans, it's the most expensive clinical entity to care for. And there is a lot of variability in terms of how cancer is managed and the number of medications that are coming out year over year, because the FDA process has really evolved over the past several years. It's a separate conversation. So more drugs being reviewed for shorter periods of time, which have an average cost of $350,000 that are getting approved. So chronic disease, so people have it longer, more people have it, the drugs are more expensive. Oh, by the way, there's more of them, and there's more variability. That variability and waste, right, leads to increased costs in the system.
Well, also, to some extent, you could make the argument that it's a product of us doing a really good job. Right?
Totally. Look, if you have cancer, it's never been a better time to have cancer. 100% agree.
Progress in developing new treatments and keeping people alive and giving them that, additional months or years or whatever it may be with their families is hard to put a price tag on. So
amen. And that's a health ethics conversation.
It's a conundrum.
Totally.
Right? Doing a great job, but it's costing more money, right?
So many of the diseases that now there's gene therapy or medications or treatments, right, that ideally improve quantity and quality of life, health span and lifespan. Absolutely. And that's wonderful. And that's why we're scientists. And yet, again, public health wise, how do you manage that for populations becomes very tricky. Particularly think about this if you're a self-funded employer. If you're an employer who decides to pay for your own health benefits, right? How do you do that when you have one or two patients who are costing $1 million a year? It gets very hard.
It's obviously a complicated question to answer, but I think in part the answer is that we have to figure out how to save money where we can. And there is an argument that's being made that I tend to agree with, is that there's a lot of waste in utilization management in terms of dollars that are spent.
Yeah, I
Um,
agree.
because you're essentially paying people to gatekeep care, which is then therefore increasing the overall cost burden of care. And so I feel like utilization management is an area that needs major disruption, because the cost of doing utilization management is not insignificant. And then when you take Medicare Advantage plans, for example, that rely on heavy utilization management as sort of like their model of doing things to kind of keep the cost of care down, it sort of, I think, has this paradoxical effect where you're spending so much time and effort and money on doing utilization management that you're not necessarily lowering the cost of care. You're just spending money on utilization management.
Yeah, I think ideally there is no UM. Like in an ideal system, like everyone practices like perfect clinical evidence-based medicine. We have access to all the beds that we need, right? We have access to the right sites of care. We've agreed on the medications that we're using. We've agreed on the care plans. Again, systems like Kaiser, for example, it's pretty refined in that regard. This is your consultant. This is where they're getting their procedure, and this is the formulary. Mm-hmm. And so I agree with you. And I think most, private, including non-for-profit health plans, most people don't realize that most health plans are not-for-profit. Their margins are, 1%, would agree with you. And that's why, again, the vast majority of claims that come through do not need or require, it's part of it's the variability piece. How do we work collectively to reduce variability? And I'll give you an example, right, which is back to cancer. So one of the things that we're working on is with our oncologists, can we agree, for example, that NCCN guidelines make sense? Can we agree on, class 1A NCCN guidelines? And not everyone may know what that means, but can we agree that the specialty societies, your specialty society, who has said for this clinical entity, this is the treatment, can we agree that that's what it is? And if you abide by that, there's no prior authorization, and it goes right. Patient gets what they need. Patient gets exactly what your specialty society said. And I'll tell you what, we get pushback from oncologists about that. So we're working with leaders in oncology in our state to say, can we all just agree upon, can we come together and agree upon a few fundamental things? And then guess what? We're happy to repurpose those 3 physicians that were doing UM or send them on an early retirement if they so choose. 100% agree with you. It's really back to the variability. And then there are other things, for example, how do we work collectively with hospital systems that incent certain care, that don't want the colonoscopies to be done in ambulatory surgical centers. They want them to be done in the hospitals. So how do we work with systems to ensure that there's credentialing for physicians and that they're building ambulatory surgical centers where people can get their lower acuity day procedures, endoscopies, colonoscopies, colposcopies, minor cardiovascular procedures. You and I could go on in the list, and do them in a venue that is safe and effective, that physicians love practicing in, that's 10 times less expensive.
Well, it's really refreshing to hear you talk about using the professional society guidelines in place of utilization management, because I think I speak on behalf of most of my colleagues when I say that one of our hugest pet peeves, and I don't have any experience in Idaho, so I can't say it has anything to do with the insurance company that you're currently working for. But one of our biggest pet peeves is when we're following the guidelines and it still doesn't get covered, or we're following what we think is best practice based on our professional society and it doesn't get covered. And
yeah, I can't speak to that, but I totally agree. I will say in general, there's a group called the Consortium. This is publicly well known. The Consortium is a convening body for Blue plans, so Blue Cross and Blue Shield plans across the country, where their physician executives come together, physician leaders come together, and try to make sort of consensus statements to this point about how can we reduce waste and variability in the system and ensure clinical efficacy and safety. And we had a recent conversation, for example, talking about vaccines. Right? There's so much noise about vaccines, right? And who do we trust? And what I will say is, in general, my conversations in those meetings, that it's the specialty societies, our colleagues, right, that we look to when it comes to, what is the actual evidence. The reality, I will tell you, and this is something that physicians don't see, is there is variability, right? So there is variability in practice. And I can tell you that most of what gets hung up are those points of variability when physicians, for example, are looking to do procedures that are generally considered, for example, experimental. And even according to their society guidelines, they're experimental. I'm not saying they're not valid, but how do you justify? The cost is 5x, right? How do you make those kinds of decisions? They're difficult decisions. But I would say, the goal is not to say no. That's not the goal.
I mean, you have to allow for some of that because otherwise you stifle innovation. Like if you don't have a pathway for physicians or surgeons to perform procedures that are innovative and new and not yet part of the guidelines, then
I think that's largely, to some extent, you'll see that happening in academic centers. And that's also why, at least in most health plans, certainly the one, that I work for, and I believe it may be legislated that medical policy is reviewed on an annual basis. It's updated and reviewed and they're publicly available. So medical policies for insurance companies are publicly available typically, and they're reviewed on an annual basis. And they're required to be, I believe, by NCQA or whatever your accrediting quality body is. So you're right. We absolutely have to do that. But we need, just as scientists, again, we need some kind of, it doesn't have to be a double-blind, placebo-controlled randomized clinical trial. But we do, I think, all believe in the scientific method, and we want to ensure that there is, at a minimum safety and we hope efficacy.
I just want to say it can be crazy making on the provider side of things because each insurance company that we're contracted with has different guidelines.
Totally.
And so it's sort of like a nonsense kind of exercise to try to figure out like, okay, I have these patients that have the exact same issue that need the exact same treatment. And if they have one insurance company, it gets approved. And another insurance company, it doesn't get approved. And the next insurance company, it does. And the next one, it doesn't. And it's like, I know you publish your guidelines, but it's crazy making for providers to even keep track of, if you think about like, there's probably thousands of things that we're recommending or prescribing or ordering for our patients in primary care because the scope is so broad, right? And so if you think about all the different medications that we prescribe in primary care, all the different kinds of imaging studies, all the different kinds of specialist consultations or whatever it may be, and then you multiply that times each of those things has a different cost depending on the insurance company. Each of those things is either going to get approved or denied depending on the insurance company's guidelines. It is impossible as a provider to keep track of any of that stuff. And so what ends up happening is you kind of just throw spaghetti at the wall, and see what sticks to some extent. You try to order the things you think that the patient needs, and you hope that it can be affordable. You hope it can be covered. You hope you don't have to argue with somebody on the phone about whether they need something or not.
It's totally frustrating. I don't disagree with anything that you said. I think ideally there's much more overlap in those Venn diagrams in terms of clinical guidelines. You mentioned the medication piece, and that certainly is, I think, an area of common ground and frustration between physicians and health plans, that there's this third party, right, drug companies and for the pharmaceutical industry, which again, I mentioned it earlier, people are living longer. There's more great choices. There's incredible innovation. It's never been a better time to have, in many cases, terribly sinister diseases because of the research and innovation that's done there. And it's unbelievably expensive, right? And there's high degrees of variability, and there's major PBMs that control the pricing, which are these big middlemen between the pharma companies, right? And ultimately the patient and sometimes the insurance companies. So the drug landscape is incredibly complex and complicated, and no doubt adds a layer of administrative burden and cost variability to the system. Look no further than GLP-1s.
Yeah, no, I hear you.
I think, most of us would agree that if GLP-1s were the price of statins, right, we would be having different conversations. But they're not, and they're not affordable at scale.
And yet, they have the potential to reduce the total
100%
cost of care and burden of care, because if you help people lose weight and control their blood sugar,
right,
and you do that in the most effective way that we've ever been able to do before, you're going to have a healthier population.
No, everyone agrees, but here's what I will tell you that, and this is what employers will say. I'm lucky if I have my people for a year or two.
Right. So it's sort
or
of
on the individual exchange, exchange, right? So no one wants to assume that expense because they're not going to get the downstream benefit.
Right. So it's a massive passing the buck that gets passed from one to the next. And then who loses at the end of the day? The patient is the one that loses.
That's correct. I'm not disagreeing with you.
And it's not like any one, say, insurance company's fault or one employer's fault or whatever, whoever's making the decision on to cover it or not. It's the way that the system is structured doesn't support a mindset of this longitudinal approach to care, because we're just focused on what is my cost going to be this year,
Correct.
not necessarily what is my cost 15 years from now, because this person isn't going to be on my health plan 15 years from now. They're probably going to be Medicare at that point in time, right?
Well,
So
I wonder if we're inadvertently making arguments for single payer healthcare, right? I mean,
yeah, I mean, I get this question all the time. I have guests come on my podcast and they ask me, "What do you think? Do you think we should have a single payer system?" And I still feel like we're looking at this a little in a little too narrow-minded of a way. We're looking at this as two options, right? We're looking at it like we have the
binary.
system we have now, which is clearly not working and is doomed, in my opinion, unfortunately. We're going to see, I think, worsening of the current situation, and the things that are causing challenges are just going to get bigger over time because of the trends in the aging population, the increased burden of chronic disease, the more innovation that's coming out, that's becoming part of a standard of care to keep people alive but cost more money. All of these dynamics, right, are not going away. They're only getting bigger. But I don't know that the single payer system is the answer. I think that's sort of a knee-jerk thing that people kind of put out there because that's the only other thing that we know of, that we can think of. But I think creative minds and smart people on the business side and on the medical professional side can put their heads together to come up with something that's better. There's a lot of single payer systems out there that are also flailing, that are also causing delays in care because of rationing of care and because of not enough resources, and all these problems don't just disappear just because you go to a single payer system. Certain things can get better. Maybe we have more aligned incentives, more cohesiveness, right? Like you have that kind of longitudinal perspective on the population, that you're not having people bounce from one health plan to the other. You don't have 50 million different prices for things. Everything has one cost associated with it. Maybe, you can negotiate more effectively with drug companies for prices, right? Because you're not having all these different players that are making their own contracts that are all different from one another. But I still think then you also run the risk of taking away any idea of competition in the healthcare marketplace, which I think is not necessarily good. There can be complacency. Maybe I'm wrong, but I guess I get concerned about that. And so I don't have the answer. If we went to a single payer system, I don't think we would want to model it after the other systems that are out there, because I don't think that they are working very well either. Maybe there is in some ways better than what we have, but certainly a lot of challenges and frustration that I hear from patients of those systems in other countries. So how do we take our entrepreneurialism, our innovation, our ability to disrupt industries that's so classic American, and leverage that skill set and apply it to healthcare? Because I don't think it's choice A or choice B.
Yeah, I'd make it even simpler. Like, we have to stop doing what doesn't work. So, in most cases, I think fee for service is just an outdated entity that doesn't really necessarily put the patient's best interest or the clinical outcome front and center, right? It's a payment mechanism that I think by and large, in the system that we have, doesn't necessarily make sense. How do we think about reducing, waste in the system, whether it's, PBMs, brokers? No offense to my brothers and sisters out there who are doing that kind of work. Are there, pieces of the system that could be managed more efficiently? How do we think about, the hospital? How do we reinvent? And there are tons of smart people doing this, right? What is the purpose of a hospital? How can we work collectively to create venues of care that are not as expensive and inefficient, in many cases unsafe, as the hospital? I would even look back further to, how do we simply scale physicians? How do we think about medical education, both undergraduate and graduate medical education? How do we make the career that we've chosen, right, one that continues to attract people that are bright and intrinsically motivated, right? It's not an easy decision, right? I question mine. I can only imagine, what it's like for people nowadays, with a lot more professional options and a lot higher barrier to entry to get into medical school from a cost standpoint. We need to align on sort of where the common ground and shared purpose is. and begin to tackle some of those things. It will require trade-offs. And I think back to also where I started, we still have to get our heads wrapped around how are we going to incent and manage primary and preventive care.
100%. I'll give you a personal anecdote. So a few years ago, I ended up having cholecystitis. And at the time, I didn't know that I had cholecystitis. I thought I might have a gallbladder issue.
You
and I
don't
went
exactly fit the bill.
No, but I did end up getting my gallbladder taken out eventually, because my liver enzymes were in the 500s. And I had leukocytosis and all the things. But anyways, so the week leading up to my surgery, I went to a hospital local to my area. I won't name which one. And I was there for probably a total of 4 or 5 hours in the emergency department. They ran basic labs. They gave me IV fluids. I had some IV nausea medication. And I got initially an ultrasound, which showed a distended gallbladder but no stones. So then they did a CT scan because they were just trying to see if there was something else going on, which was inconclusive. And then I got discharged. My bill for that was like $5,000 or $6,000. So then in my own practice, I have a patient that comes in, they have right lower quadrant pain, okay? We have relationships with imaging centers that are outpatient private imaging centers where I can get same-day CT, which is something that we've worked on cultivating because we want that type of resource accessible to our patients. Because honestly, our patients don't want to go to the hospital for these kinds of studies. We say, we don't want to keep people from going to the ER. Well, people don't want to go to the ER unless they really have to go to the ER, right? Anyway, so we do in-house labs because we have the ability to do a CBC, a comprehensive metabolic panel, a urinalysis. This was a patient that was essentially out of network, so they're doing self-pay in our office. For all of that, we charged, at the time it was like $175 for the visit, for the labs, and then we sent them to an imaging center. They didn't want to go to the ER, they didn't want to go to their network hospital or whatever. They paid cash for that CT scan. I think it was like $400 or $500. Patient had appendicitis and ended up getting direct admitted by their surgeon to the hospital, to have their surgery. There have been other cases where I've had patients with, like, say, it turns out it's a kidney stone, right? And so they don't even need to be admitted to the hospital, but they essentially get the same workup and then get discharged to follow up with urology as an outpatient. So for that care, the total cost of care is less than $1,000, of which we made, somewhere between $150 and $200. And I'm the exact same person that you would see if you went to the emergency department, right? I'm an ER doctor by training. And we're able to do that kind of thing because we build our schedule in such a way that we leave flexibility in the schedule for those kinds of acute visits. That's essentially impossible in certain health systems where the wait time to see primary care is multiple weeks out. And the other aspect of it is it fair? Is it fair that we got paid $150 to $200 for this kind of care, this level of expertise, and the savings that were experienced by the health system? We don't get to share in those savings, right? But if the patient went to the hospital is going to make money on that visit to the tune of $5,000 or $6,000 just for the emergency department part of that visit. What are your thoughts on that? And how can we better reward primary care? And I think you'll agree with me on this too. And you've worked for Kaiser, so you've worked in an integrated health system where you've got essentially physicians are on salary for the most part. You're not necessarily getting paid based on what you're billing, but in primary care, in a fee-for-service model, and everyone keeps saying, fee-for-service is bad, it's so expensive. Well, in primary care, fee-for-service model is not financially viable. It's not sustainable. And health systems look at primary care as the loss leader, that's the feeder into the hospital or into these more expensive procedures. What needs to change?
If I could answer that question, I'd probably not be doing this podcast, with all due respect. What I will say, though, is that the good news is we're talking about these problems, because as the problems you don't talk about become multiple problems. It's the problem that you're not talking about it. So look, you're right. It's a classic case. What I will say is that, again, you have competing incentives. You have delivery systems that in many cases may be for profit or not for profit. They're still for profit, right? In many cases, there's private equity involvement, right, in those delivery systems. And they are incented to deliver care in certain ways in certain venues. You have physicians who have too much to do with time they don't have and can't be bothered. If someone shows up, we're just going to take care of them. And then you have patients who are stuck in the middle that are confused and frustrated. And oh, by the way, managing pain and worry and anxiety and fear and challenges of medical literacy and all the social drivers of health, right? No wonder it's hard.
Mm-hmm.
I think all I can say is back to sort of the grand round, it's about having conversations together as all components of the system, the deliverers of the care, whether they're employed or independent, the venue in which they deliver care, right? The hospital or the system, the health plan who's paying for the care, and in some cases, the patients who are seeking that care. Although I would argue everyone in that room hopefully can put that patient hat on to come up with those kinds of answers and solutions. And sometimes it's about addressing a single area of care, like we talked about, like acute care, right? How are we going to ensure that there's digital means, primary care access, urgent cares, and emergency departments? How are we going to triage, to your point, one or the other? How are we going to incent the payment or disincent the payment accordingly? How are we going to enable clinicians to have point of care testing so that they can work to the top of their license in their clinics and mitigate some of the lab issues and licensing issues that come with point of care testing? And I think part of it's just being mindful. We know that advanced imaging is more expensive than not advanced imaging. We know that certain medications are more expensive than other medications. We know that procedures done in certain venues are more expensive than other venues. I think part of it's just a general mindfulness. And I'm not suggesting we don't have that. I think we do.
I think to solve the problems in healthcare, there's so many different levers that can be pulled. I think one trap we can fall into is thinking about this from a utilization management standpoint and saying, okay, well, we need to do less procedures, order less tests, only the ones that are really necessary, et cetera, et cetera. I mean, I get that. With how the system functions now, that makes sense why that's something that we need to be mindful about. But to some extent, it flies in the face of where we're going as a society that is very data-driven, with AI and so much data that we are now able to collect on wearable devices, and the cost of technology, relatively speaking, coming down. Even just the ability to do on your Apple Watch an EKG, right? Just a rhythm strip tracing on your Apple Watch. 15 years ago, that was like crazy advanced technology. Now it's like everybody has one. I think that if we think a little bit outside the box, take the idea of MRI, for example. Why is an MRI so expensive?
Well, it's not. It depends on where you get it. So, for example, right, there are facilities where MRIs are $500, period, start to finish, all inclusive. That's the whole soup to nuts. And there are others where it's $1,500 and $2,000, right? So you're back to variability. In large measure, it's facility fees, right? It's trying to drive revenue, right? Yeah. And I'm not arguing that systems shouldn't drive revenue, but that 3 or 4x difference comes from somewhere,
right?
So they're not always that's the variability in the system that we have,
right? So if you take the example of the patient that has, let's just say, back pain, low back pain, right? And you start with an x-ray, and the x-ray of their lumbar spine looks normal. And then you follow kind of the utilization management protocol of, like, you send them to physical therapy and they try that for 6 weeks and then they don't get better. And then finally, they've met the criteria. So you can now order the MRI. So you get an MRI and it looks like they have a radiculopathy and they could benefit maybe from an injection or something, right? That solves their pain. If you kind of rewind that, and if the MRI weren't so expensive and you could just go straight to the MRI because you're a good diagnostician and you can tell that this patient is having a radiculopathy and it's not a fracture that you're going to see on the x-ray, or it's not some other pathology that shows up on an x-ray, and you could just order the MRI and it wasn't a cost barrier, you could have saved all of that PT, all of that time. You could have gotten them straight to a specialist who could have done an injection on an outpatient basis that's not overly expensive. And the patient would have been better, faster, and happier. And maybe the cost of care would have been the same or would have been a little less. So I guess all I'm saying is part of the challenge in innovation is if we get too stuck into the current framework of what things cost, without accounting for the fact that maybe one of the levers we need to pull is trying to create incentives that allow for different cost structure to bring down the cost of these procedures and medications and things that were historically expensive, but should become relatively inexpensive because they're not that hard to do given the state of where technology is at. And even medications, I understand that there's a cost that goes into developing a new drug and the drug company wants to recuperate that cost and et cetera, but there's still tons of money being made on these drugs, let's be honest. I mean,
yeah, for sure.
There's room for the government to come in and regulate how much profit can be made off of a given drug. So I guess all I'm saying is, I'm just trying to be a little bit cautious around being pigeonholed into the current paradigm, I guess is what I'm trying to say. Because as society and technology evolves, we should have more and more technology at our fingertips for a lesser cost. That's kind of...
Well, we do. I mean, we certainly are seeing, I think to your point, the scale and the use of technology, which is allowing physicians in many cases to do more with less clinician capacity. So if you can have, cardiologists that are monitoring patients, with iPhones, right, at scale, and not having to walk around and order Holter monitors or event monitors, et cetera, or you have intensivists that can virtually manage ICUs and see multiple patients through they're getting beamed in, or we've seen it with teleradiology where you have patients that are being able to be cared for by radiologists that are far, far away. So I think we have seen technology bring scale and economies of scale. I think we're seeing it now more than ever, just in terms of documentation at the bedside. When I saw my primary care physician, for example, for my annual wellness visit, and he popped his iPhone up there, and by the time I walked out the door, my note was done, and he basically took his iPhone, popped it up there, and it was done. We reviewed it, and I was out the door, and he was on his next patient. He's seeing 3 more patients a day, not because he's being crunched in to see more patients, because of the time and the bandwidth to see more patients. So he's seeing more patients, and he has more time to do that because he's spending less time clicking the computer. All of us would like that. So I think these are some of the advantages that we are seeing, certainly with better technology, and I think we'll continue to. The question is, how do we use it, where, who pays for it, etc.
As our discussion came to a close, I asked Dan to reflect on his experience working for a health insurance company in a capacity that has the potential to affect hundreds of thousands of lives, as compared to working in a clinical setting in the hospital, helping one individual at a time.
It's very different, right? A hospital is very different than an ambulatory clinic. Working in an operating room is very different than looking at a pathology slide. And I think working in a health plan is different than working in a medical group. The culture is different. It's the classic example of the elephant, right? Of one person's, feeling the tail and they think it's this kind of animal, and one person's feeling the foot and they think it's this kind of animal, and one person's feeling the trunk. They're all blindfolded, and yet they're all essentially feeling and working with an elephant. I think they're all valuable. I think the health plan perspective is valuable. It's one that I think begets and breeds a lot of quantitative thinking, the math and the analysis that transpires to think about how do you take risk on populations and pay for something that's highly variable and do so at a way that's at scale is critically important. How do you try to integrate and provide support for physicians and patients simultaneously? How do you augment the clinical practice of medicine with third-party products like care at home, like additional scale of virtual cardiology or virtual primary care or virtual urgent care or virtual behavioral health services? How do you bring those into the care landscape, knowing that there aren't enough brick and mortar clinicians in many cases to provide those services? How do you address social drivers of health and hire care managers and care navigators and medical assistants, and provide more venues of care for those people to work in? How do you think about populations that are rural and disparate and frontier that most clinicians never see, but health plans are kind of faced to deal with? But it culturally can be very different, and which is again why I think it's really important to have physicians and have clinicians in all aspects of healthcare, right? Not just at the bedside, but in health plans and in innovative technology companies and in law firms and in legislature. I think it's important that we bring our expertise and our insight and our clinical moral compass to bear from all sides of the healthcare picture. It's the only way that our voice and our expertise is going to continue to make impact.
Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare through conversation. If you liked what you heard today, please follow this podcast and share it with your family, friends, and colleagues. By spreading awareness, we can bring about change. You can also connect with me on Instagram at drjoymd. That's DOCTOR Joy MD.